As you know, the Congress's overarching theme is all about innovating, integrating and inspiring in the context of a 21st century healthcare world. And I'm very conscious of what Elizabeth Teisberg talked about prior to lunch about the notion of health and care as two words rather than one, to challenge ourselves at the beginning of this next session to consider what that actual separating of health and care, but in terms of the way we sentence it, but actually connecting them and the way we practice it, might actually do. The important challenges, of course, are multiple. They do include the very important technology, which is the mixed blessing in the modern age. We've got issues about changing demographics and disease profiles, chronicity. I noticed that the Royal Colleges in the various different countries are now trying to train up their professionals and the other health professionals within the system more broadly and management to manage the transition from acuity to chronicity and all the challenges that are inherent within that. Of course, there's the issue of money, always the issue of funding and the pressures of funding. Models of care. What should we be doing? How do we make those decisions? How do we determine how effective they are? Another point that was made about not just the outcomes of care, but outcomes during care. And also the issue about workforce pressures. The important thing about actually recruiting and retaining, as we know that health workforces around the world across disciplines are struggling to retain, let alone recruit people that actually can be adaptive and committed over time, be supported to be committed over time with their work. And there's obviously many more issues involved as well. The other thing that's important here is it's not just about the issues, we're also very keen to talk about what we can do about it. What are the solutions potentially? These are no doubt multifaceted, multi-pronged, and this is the broad context of how do we do that across boundaries and borders. And they're not just geographic boundaries and borders, but cultural, language, cultures of medicine, not just ethnicities, age, other factors that actually determine how we decide what we do and where we do it, and then how we determine how effective that is, even to the very heart of what is health. Today we're examining how hospitals and health organisations connected with hospitals actually engage in these spaces, and even what a hospital means in the 21st century. And this is this issue of volume to value. Essentially, this is the challenge that is not unique to any particular jurisdiction, but one jurisdiction that has actually been exploring and moving into this space very actively is Singapore. Now, first keynote speaker for this session derives from Singapore, and to introduce that keynote speaker, I would like to introduce you to Natalie Lawandi, who's actually from Medtronics Australia, another one of our sponsors who's actually made this Congress possible. Natalie?
Making healthcare better is our priority, and we believe medical technology can play an even greater role in improving people's lives. With challenges facing families and healthcare systems, such as rising costs, ageing populations, and the burden of chronic disease, we are using the power of technology to take healthcare further together. Innovation and collaboration are central to who we are. Since the late 1940s, we have been working with others to alleviate pain, restore health, and extend life. Today, we are a medical technology leader employing more than 84,000 people worldwide, 950 here in Australia and New Zealand, and offering therapies and solutions that enable greater efficiency, access, and value for healthcare systems, providers, and the people they serve. It gives me absolute great pleasure to introduce Dr. Daphne Khoo today. Dr. Daphne Khoo is the Deputy Director, Medical Services Healthcare Performance Group at the Ministry of Health, Singapore, where she oversees all national patient safety, clinical performance management, quality improvement, and utilisation review programs. She is also the founding Executive Director of the Agency for Care Effectiveness, Singapore's National Health Technology Assessment Agency. Dr. Khoo trained as an endocrinologist at the Singapore General Hospital and the Cleveland Clinic in the USA. She is a former president of the ASEAN Federation of Endocrine Societies and recipient of the Asia Oceania Thyroid Association, Nagataki, Award for the contributions to thyroid research. From 2011 to 2014, Dr. Khoo was the Global Chief Medical Officer of a private healthcare company within the healthcare facilities in 11 countries, including India, Vietnam, Australia and Hong Kong. Her current main area of focus at the Ministry is co-driving the Beyond Quality to Value workstream alongside colleagues from the healthcare financing. Dr. Khoo, thank you.
First of all, I'd like to thank the organising committee for this very kind invitation, this opportunity to share the work that we're doing in Singapore. I must say that this is my first trip back to Brisbane after 15 years, and I'd forgotten how absolutely gloriously beautiful it is. My son actually just completed his undergraduate work in Monash down in Melbourne, and I just gave him a call a couple of days, and I said, when you're thinking of coming back to do your masters in Australia, and I really think you should consider Brisbane. It is just so beautiful. All right, so now I'm going to talk about this. I hear a lot of speakers have talked about beyond volume to value, but our focus is beyond quality to value, and I will explain to you how we've taken this journey, and hopefully, now at the end of this whole talk, what I want you to have felt was that you had fun and that you learned one or two things, and that are one or two things that you can bring back and apply to your work. And if that's been achieved, then I think I've achieved the objective of my talk. A little bit about Singapore. I think for the Australians among you, you will know Singapore well. For many of you, this would have been a transit stop to another country. It's a very small country, only 720 square kilometers. In terms of the GDP capacitor, it's about per capita, sorry, it is about the same as Australia, and our life expectancy at the moment is around 83 years. We spend about 4% of GDP on health, which seems a low level to spend, considering that we actually have very good life expectancy. But it should be remembered that Singapore is actually a very low tax jurisdiction. Our maximum personal tax is only 22%. So that's the reason that there is a lot of relatively high out-of-pocket spending in Singapore, because the tax system is low, and we have a fairly unique system in terms of our taxes and the way that healthcare funding is carried out. Now, how did I get involved in this space? Because I started off as an endocrinologist, and I was extremely interested in actually basic and translational as well as clinical research in my field, which was thyroid. And one day, when the Singapore divided the country into two major healthcare clusters, and my healthcare cluster chief came to me and said, "We'd like you to go into administration." And that was in 2000. And I said, "No, I'm very sorry, but I'm very happy in clinical work. I'm very happy in my research, and I have no desire to do administration." Now, what happened was that in 2003, Singapore was hit by SARS. And for those of you who come from countries that have ever been hit by those types of epidemic, it is life-changing, right? For 2 to 3 years, it's not the healthcare system only that came to a complete standstill, but the entire country came to a complete standstill. And people we knew, my friends, in healthcare, colleagues that I had worked with, friends, people died, right? People died because of infection control issues. And thereafter, in 2004, they approached me again and said, "Would you be willing to take over quality, patient safety, and infection control, given that we want to revamp the whole system, having learned what we have learned from the SARS episode?" And at that point, I agreed. Now, when I came into patient safety and quality at that point in time, in 1999 and 2001, the Institute of Medicine in the US had just released its 2 reports, To Err is Human and Crossing the Quality Chasm. And for those of you who have been in hospital care for a long time, you will know that these were seminal publications that basically told us that unlike the safe havens that we thought hospitals were in fact very dangerous places. And I remember in the early training sessions that we used to attend, there was always be, the first slide would often be the slide that Lucian Leap had developed, which actually showed how dangerous hospitals were, and it was much safer to go bungee jumping or mountain climbing than get yourself admitted to a hospital. And although we've put a lot of efforts into patient safety, I think it still remains an issue. Now, this is had I known that your minister was going to talk about hang gliding, I would have shown a hang gliding slide, but I didn't, so I'm using a base jumping slide. But as an aside, not that is important, the one and only time I bungee jumped was in Cairns, right? So clearly, Queensland is a place that brings out the dangerous side in me, all right? Now, I don't know whether you know what base jumping is, but apparently, I haven't tried this, and neither do I intend to. It is about throwing yourself off a cliff with a wingsuit, right? Now, this sounds highly dangerous, and I assume that if I were to try this, I would almost certainly die. But it turns out that it is much safer to go and do this than to get admitted into a hospital, and you're more likely to die of an error in the hospital than you are to die from jumping off a cliff in a wingsuit. So if you were to do this, your chances of dying would be about 1 in 2,400. And if you were to get admitted into a hospital, your chances of dying, not from your disease, but from an error due to the healthcare provision that we give you, is anything from 1 in 100 to 1 in 300. And here we're talking about statistics from developed countries. Or what more when you go, and when you talk about hospitals in developing countries, and I've seen some of these hospitals in the course of my job in Fortis, where we covered places like Vietnam and India as well, where it's not unusual to find hospitals where 2 patients share a bed, and in some cases, 3 patients share a bed. Now, I wondered, how is it possible for 3 patients to share a bed? And then when I visited a hospital, I realized 2 patients sleep on the bed and 1 sleeps under the bed, right? Now, in these sorts of circumstances, I would assume that, the healthcare associated infection rates would be astronomically high. And what more, often these countries also suffer from high levels of antibiotic resistance. So not only are you at very high risk when you get into that hospital, but you're also likely to have a bug that where the antibiotics may not work. Now, aside from the fact that this whole issue of patient safety, and being an Australian audience, I know that you're very, very aware of the problems. We also know, and what's becoming more clear is we often actually do not agree or know what is best for our patients. And here, I'm talking about the doctors who order care, right? And I will expand on this as I go along. The earliest speakers mentioned the high rate of variation, the high level of waste. Now, the Institute of Medicine estimates this waste in healthcare at about 1/3, and WHO at 20 to 40%, OECD at 20%. So even taking the best scenario, which is OECD, it means that for every dollar that is spent on healthcare, 20 cents is wasted. That is to say that if we had not spent those 20 cents, it would have made absolutely no difference to the patient outcomes. Now, what is also not perhaps appreciated is that when doctors are asked to choose treatments for themselves, they often don't choose the same treatments that they would choose for their patients. Now, why is this so? This is because, for doctors, we can make a highly informed decision. We know exactly what are the trade-offs we are making, and we might say, well, I don't want to go through this chemotherapy. I know the side effects. I know the risks and the chances that this will improve my survival, and I would just rather spend the last months of my life doing things that I want to do and being with my family. But we as doctors often don't offer that option to our patients because we feel it is our obligation to do as much as for the patient as is possible. All right? Now, I also wanted to talk about this particular slide. Now, this is a slide showing this is Korea's thyroid cancer rates, and thyroid is my field. What they did in South Korea was that they began to start a national screening program for thyroid cancer. Now, this was very well-meaning. The thyroid ultrasounds now are very good, but if I were to scan all of you in this room, the chances are about 20% of you would have a thyroid nodule. If I biopsied you, then again, we've shown in autopsy results that about, again, 20 to 40% of people will be found to have tiny, tiny thyroid cancers that have no clinical significance. The majority of these cancers, you would have lived with them your entire life and nothing would have happened. But now we've given you a diagnosis. We found a nodule, or with biopsy the nodule, you have now been labeled a thyroid cancer. Now, once you're told you have a thyroid cancer, you're likely to be sent for removal of your thyroid gland. In 90% of cases, that happens. And there are a lot of complications that could be associated with that surgery. You could have damage of your recurrent laryngeal nerve. You could get hypoparathyroidism. Or even if everything went well, you're committed to lifelong thyroid hormone replacement therapy and constant monitoring. So this is not to say that it wasn't, it was well-meaning, right? We say, well, we want to screen, and the more we screen, we pick up things, we treat patients earlier, and this is good for them. The fact is, even as things improve in our ability to detect things, it doesn't mean that we're doing more for our patients. First of all, I apologize to any South Koreans who are in the audience. I love South Korea. It's one of my favorite countries. I go to a lot of K-pop concerts, and I'm normally the oldest person there, all right? So I really love South Korea, so please don't get me wrong. I wanted to go back one slide as well. I forgot to say something that I wanted to say, and that when we talk about, the danger that we do to people by doing too much, the studies actually show that when doctors go on strike, survival actually improves. All right, and there was a paper where they did on cardiologists, and they had this hypothesis that, surely, when there's this huge cardiology conference in the US, and surely the death rates must increase because every prominent cardiologist in America is at that congress. To their surprise, the data showed the opposite, that survival improved when they were all away at the Congress, all right? So the lesson to learn is that sometimes we do too much, and in doing too much, we actually cause worse outcomes for our patients. The converse is true for nurses. When nurses go on strike, mortality increases 20%, all right? So please don't send your nurses off, all right? But the doctors can go on conference, like me, all right? Okay, now, what is the other bad news? The other bad news is we cannot afford the healthcare that is coming. Singapore has always been admired for our very prudent use of financing for healthcare. We get very good outcomes for relatively little cost. But even then, in the last 6 years, we have seen doubling of healthcare costs, and the growth rate of spending is about 11.1%. This is not sustainable when our GDP is growing by only 3% per year. Okay, what else is coming? You look at that drug there, Kymria. It's not really a drug. It's considered something called a CAR-T therapy. So this is a treatment for leukemia, produced by one of your major sponsors, Novartis. Are you out there, Novartis? It is more than 500,000, right? But it is potentially curative for leukemia. But the question then is, how do governments pay for these drugs? The next major thing that everybody's worried about is aging, because all countries, have rapidly aging populations. In Singapore's case, we are the second highest in Asia after Japan. I don't know how many of you realize that a baby born now may survive till the age of 110 to 120. All right? Because for every decade of life, we generally see that longevity increases by 3 years. So 2 years for some countries, 3 years for others. But if you sort of do the mathematics, that tells you how long we're going to live. And if for half your lifetime, you're going to have chronic diseases. Chronic diseases generally start at 50, 60. And if you're going to live with 100 for 110, you're going to spend half your life with disease. Right? What's more, towards the later stages of your life, it is very likely, or no, I wouldn't say very likely, but there's probably a 30% probability that you could end up with dementia. So how do we actually pay for all these things that are going to hit us? And finally, we talk about the precision medicine. I know that your minister spoke about the great promise that precision medicine brings. But as I showed in the example of overdiagnosis of thyroid cancers, using very sensitive ultrasound, and the same you're seeing in prostate cancer, 50% of men as they get older are going to have microscopic prostate cancer. But does that mean that they all have to go for prostatectomies? Because the reality is, just because you detect it and you send the patient for surgery, very often changes nothing, because the cancers are of no clinical significance, and had they not known that they had it, nothing would have been done. And what is the trade-off as you send these patients for surgery? You end up with urinary incontinence, there's sexual dysfunction, and there's a lot of patient regret when people realize that, well, the outcome wasn't what I expected, and I would now wish I hadn't gone for this. Okay, now this is, I like this blue box. I call it the blue box. This is the universal healthcare model from WHO. And what it says essentially is that, now we all know, and this is very commonly said, in health technology assessment circles, that there are infinite needs and finite resources. So the WHO has shown, using this model, and the clear cube represents what are the total healthcare demands that most populations want or need. And the blue box represents the resources that we actually have to deliver on what our population wants and needs. And in universal healthcare, you just try to fill up the clear box with as much of the blue box as you can. So in 2015, my government decided to form the Agency for Care Effectiveness at the Ministry of Health. This is a health technology agency, and our vision was to improve patient outcomes and healthcare value through health technology assessment. Our mission is to issue objective and reliable guidance, and we have a three-pronged mission to help patients, to help the doctors, and to help policymakers make better decisions. You'll be happy to know, because this was not an area that we had invested in, because we never had done health care technology assessment in Singapore in a big way, and that only started quite recently. And you'll be happy to know that actually 50% of the team is Australian. Right? So Australia is contributing to Singapore's healthcare efforts in this space. Now, what exactly is health technology assessment? A lot of you may be familiar with it because I think the work of PBAC and MSAC in Australia is well known. But essentially, HTA tells us whether a new technology is better value than the current standard of care. So when you have a new drug coming in that costs 30 to 50 times more than your existing standard of care, how do policymakers decide if they should cover it? How do you know whether it's worth the money that you have to spend? So basically what HTA does is really it compares over a long time horizon what are the potential benefits of using the new drug versus the old, and what would be the cumulative costs. So you do this Markov model and you map. You build this model and you map and you do projections about, well, over 30 years, if I were to use this new drug versus the old drug, what would be the overall difference in health outcomes and costs? So in a way, this is a form of value. All right? And here you can see, so you can calculate in terms of the health utility outcomes and over a time horizon, what would be the health benefits in the blue box, which is the old drug, versus the larger area, which is the new drug. And from this, you can calculate what we call an ISTER, the incremental cost effectiveness ratio, which says over 30 years, if I were to use this drug, what would be all the health outcomes my patients would gain, and what would be the overall cost. And based on the ISTER, you can tell the value of a drug. So let's say if it comes in at less than whatever limits you set it at, it could be 20,000, 30,000, that would constitute a very cost-effective drug, whereas one that's over 100,000 per quality might be considered a relatively expensive drug for the health outcomes that you can buy with the drug. Now, cost-effective does not mean cheap. A lot of people confuse the two. So, for example, Hep C drugs are extremely expensive. When they hit the market, they were about $70,000 to $80,000 for a course. However, they're extremely cost-effective because they're often curative. The problem is that very few technologies are like Hep C drugs. They are not cost-effective because the improvements in outcomes, there are improvements, but these improvements in outcomes may not be that significant, but the cost increases are always pretty substantial, which is why when you do HTA, a lot of new technologies turn out not to be cost-effective. This is another area that caused us some problems, and this was really robotic surgery. Because what happened was when in 2003, robots, the Da Vinci robots were introduced in Singapore, and we evaluated, this was a pilot, we evaluated it for 2 years, and after 2 years, we weren't really convinced that the outcomes were all that much better than conventional surgery, that being open or laparoscopic surgery. Nonetheless, you know, how doctors are, if one doctor, if one hospital has a robot, everybody wants a robot. So everybody went out and bought a robot, right? Now, then patients began saying, well, you know, the cost of prostatectomy is becoming very expensive. Why isn't the government paying for this? And then we did a HTA, and we found that really it was not cost effective because, for one thing, the consumable rates that we were paying in Singapore were very high relative to international rates. And secondly, the outcomes that we got were only marginally better than conventional surgery. But because your consumables were about another $5,000 and your additional OT time cost another $2,000, $3,000, it wasn't really value for money. But this technology, unfortunately, has become embedded in the system, and nowadays the surgeons don't know how to do a prostatectomy by any form other than robotic surgery. So I think it's important. Now, don't get me wrong, again, I'm not saying robots are bad. I'm just saying that we bought too many. And I think you also have to be ensure that you restrict the number of places that actually have high-cost technologies and that they be very, very well trained. Because the other thing we are finding is that it takes a long time to train the doctors on the robots. And you know, for the first 30 to 50, the outcomes may not be as good. And it's important, especially when we're evaluating technologies, that we understand, unlike drugs, in the case of drugs, it doesn't matter who gives the patient the drug in most cases, but in the case of technologies, the outcome is dependent not only on what the technology is, but also who is the person delivering on that technology. In the cases of some surgeons, a laparoscopic surgery may be better than a robotic surgery. In others, the converse may be true. Now, hospitals can also conduct MiniHTS, and we're seeing this happening in Scandinavia, where as a requirement for funding, hospitals may be required to do the HTAs. And here is Norway. They actually require people to do peer reviews, somebody with no vested interest, to see whether or not these technologies should be supported. In 2016, we announced the 3 Beyond strategy for Singapore, and the 3 strategies were to move from beyond the acute hospital to the community. The second was beyond quality to value, and the third was beyond healthcare to health. I think you all understand this equation. So around the same time that we launched this, we started the National Value-Driven Care Program, where we now measure the outcomes and costs at surgeon level for selected surgical procedures, and we now have this for 17 procedures. So here we can see, and we can see this data at the national dashboard for all the surgeons doing the 17 procedures. We can give a surgeon a split on how it is, how you tend to spend when you're doing the procedure. So how much of this goes to OT time, how much of this is spent on drugs, how much on radiological investigations, lab tests, so on and so forth. So they can see how their practices vary from their colleagues. And here what we did was we actually looked, this is total hip replacement, and when we looked at the data for the total hip replacement, we found that 2 surgeons, the median ALOS for this procedure is 4 days, but we found 2 surgeons who could do it within 1 to 2 days, so their average length of stay was only 1 to 2 days. So we went further into the data, we did a deeper dive, and we looked to see how are their outcomes, and we found the doctor, the orthopedic surgeon with the shortest ALOS, also had the best outcomes. All right? So what we do in this program is we bring the groups of specialists together, and we ask them to pick on 6 parameters that we consider outcome measures. Now, ideally, of course, you want a disease-specific indicator, but where that's not possible, we tend to choose administrative data. So they choose these, they happen to choose these 6 indicators, and in order to get 1 point, a surgeon has to fulfill all 6. So it's an all-or-nothing composite indicator, and in the case of this particular gentleman, his CQI score is 86.2%, which means that, to say, in 86.2% of his cases, he got perfect scores, right? And his cost, 15,000, so the range in cost was about 12 to 20,000. He's not the lowest cost, but I mean, given that he's got the best outcomes, I think his costs are pretty good. So we also then track over time to see how they shift. And of course, the further they shift upwards and into this quadrant, then we know that the program is working. And currently, we have these for 17 procedures. So what do? We look to see who has the best outcomes. What are these surgeons doing differently? Can we replicate this? And if so, how exactly do we replicate it? Because you need to have a spread strategy. Okay? It's not been easy to get stakeholder buy-in. It goes back to you have to convince people why. Why are we doing this? Very often when the message is cost containment, the clinicians switch off, right? So I think when you're working with clinicians, you have to be very clear. What is the case? The case for the burning platform, is it very clear? Can you convince them? And secondly, can you frame your vision in a manner that is inspiring? And so with a view to that, we sort of learned the Scottish we learned about the Scottish realistic medicine approach, and we thought, okay, we're going to roll out something similar, not quite exactly the same, but we wanted to preserve all the elements of quality while adding the components of value-based care, and we wanted to talk about this in a very positive way that would appeal to clinicians. So this is called right care. In right care, we have right choice, right perspective, right practice, right time, right place, right price, and right data. And I'll talk more about right choice and right perspective. We mapped this against the classical 6 domains of quality, and we ensured that we did not lose anything because we did not want clinicians thinking that we were dropping quality to focus on costs. And so it is the quality framework, but we've added on optimal site of care, because increasingly we're recognizing that a lot of care that we think is medical is actually social, and we have to find the right people to take care of them. Value-based care is coming in a very big way, and a data-driven decision-making. This is a nice infographic that's coming out of BMJ, and this is called the Rapid Recommendation Series. I think a lot of doctors and patients don't realize that medicine is extremely uncertain. There are no black and whites, all right? It is really 50 shades of gray, right? So, I mean, the thing is that I talked about the fact that, you know, about the difficulty of making a decision in thyroid nodules, in prostate cancer, when you know you have a positive diagnosis, but you're really not sure whether it's in the best interest of the patients to pick one option or the other. It will be much worse when precision medicine hits us, because we really, really cannot accurately predict the course that the disease would take in individual patients. And we have to have that discussion with patients so that they fully understand the choices and the risks. And you see a lot of organizations now beginning to go down the path of shared decision-making. So really, you know, sort of no treatment no treatment for me without me, ask me 3, and of course for value-based healthcare, you're seeing prompts come in a very strong way, and these are the patient-related outcome measures that a number of countries are trying to roll out, and ITROM is promoting this heavily as well. And so, in the case, I mentioned that we started off, the Agency for Care Effectiveness, we started off with health technology assessment, and there all the evidence and research was used to really help us to make policy and management decisions as to how we invest our resources. And we've just formed the Appropriate Care Office of the Agency for Care Effectiveness, and this branch of ACE will actually focus on patients and on doctors. How do we give them the information that's out there? There is so much information. It is extremely difficult for doctors and for patients to understand what is the best option for that individual patient. Okay. Now, of course, all this has come with mixed responses. In some cases, there's been tremendous enthusiasm, and in many cases, the naysayers will say the usual things that they say to all of you, right? The data is not right, my patients are sicker than everybody else, this is nothing but cost-cutting, all right? And the reality is that we are in a difficult place. All of us as healthcare leaders, and I'm sure that many of this room are healthcare leaders, it is a difficult time. We have to take people to where they do not want to go. All all right? And here is Moses with the tablet and with the 10 Commandments, and they're asking, what about healthcare, right? So the thing is that, like Moses, as you lead your people, hopefully it won't take you 40 years, but there will be times of confusion and frustration, and I think there will be wrong turns, right? Thank goodness in this age, we have Google Maps, and you can turn to many people. And the Google Maps that we have are these communities of practice that we have, such as these, where we can really learn from each other and learn from each other what to do, what not to do, and share information and knowledge. Okay? And as we studied many healthcare systems. Singapore has a habit of doing this. We try to learn from, we go to visit various countries, and we try to bring back best practices for various countries. And when I've seen and studied those organizations that have succeeded in major change transformation, it really is about leadership, passion, commitment, but most of all, trust. It's very, very hard to get true change if you don't have trust. And that concludes my talk. I wish all of you good luck in this journey. Thank you.